Hello, we'll begin our webinar in about 2 minutes. The webinar will begin in about 1 minute. Hello, welcome to the National Consortium of Telehealth Resource Centers Telehealth Hack Series, Post-Acute Care and Long-Term Care Facility Pandemic Response Best Practices and Lessons Learned. My name is May Kwong. I'm the Executive Director at the Center for Connected Health Policy, which is the National Telehealth Policy Resource Center. Next slide, please. Please know that any information that you provide today to the consortium will not be used. We will keep that private. Next slide, please. The telehealth resource centers are 14 resource centers underneath the same grant program at HRSA. There are 12 regional resource centers that cover specific states and 2 national centers that cover policy and technology. 14 telehealth resource centers work collaboratively together to provide technical assistance for those who have questions regarding telehealth, how to start a telehealth program, and any other issues related to telehealth. Next slide, please. For those of you who may have joined the hacks back in the summer of 2020, they were underneath ASPR. They were transitioned over to the telehealth resource centers beginning in October 2020, and we will continue the series through March of 2021. Next slide, please. A few tips and notes for today's webinar. Please know that your phone and computer microphone has been muted. If you have a question for our panelists, please use the Q&A function. The chat function should only be used if you need technical assistance with Zoom. Also know that you can adjust the video sizing on your Zoom sliding feature bar, and also closed captioning is available for today's webinar, the button you will be able to find on the toolbar. The webinar is being recorded and it will be posted later on the consortium's YouTube channel and our website about 48 hours after this webinar. Next slide. And the next couple of slides are about the disclosure policies that we have related to the continuing education credits associated with this webinar. Next slide, please. More information on the staff that worked on this webinar. Next slide. And the joint accreditation and credit designation statements. Next slide. You will need to create a profile on Learn on Demand if you have not asked for CE credits for previous telehealth hack webinars with the TRCs. This is very simple. You just go to that URL, create a profile, and if you attend future TRC webinars for the hack, you'll just be able to log onto that profile. You do not have to do that twice. But if you are new to obtaining CE credits for the TRC telehealth hacks, you will need to create a profile first. Next slide. You will be able to access your certificates in that Learn on Demand profile. So you would just log in, find the appropriate webinar, and then be able to just follow the instructions on the screen. Next slide. There is a deadline. If you are wanting to get CE credits for this particular webinar, you must complete the information by February 10th of 2021. That is a hard and fast deadline, so please be aware that that is the date that you will need to complete any information by, any requests for your CE credits in order to receive them. Next slide. And again, just another reminder of the deadline there and where you can find the Learn on Demand URL. Next slide. So for today's agenda, we will be hearing from Lori Archibald Panot and Justin Muter, my apologies if I pronounced any of that wrong, will save questions for after their presentations, and then there'll be closing remarks. Next slide. Today's webinar will be facilitated by Dr. Christian Ramers. Dr. Ramers is the Chief of Population Health and Director of Graduate Medical Education at the Family Health Centers of San Diego, a large FQHC system serving nearly 200,000 medically underserved individuals throughout San Diego County. He is board certified in internal medicine, infectious diseases, and addiction medicine, and is particularly interested in HIV, HBV, HCV, and service of medically underserved immigrant and refugee populations. So I'll now turn it over to Dr. Ramers.
Thank you so much, May, and good morning or good afternoon to everybody. We have a really exciting session today that really addresses one of the most critical aspects of the response to COVID and the use of telemedicine, and that is addressing how to use this technology in post-acute and long-term care facilities, where up to 40% of the actual deaths that have happened in COVID in this population. I want to remind everybody, if you have questions, please use the Q&A function on the bottom. That, as May mentioned, the chat is for chatting, the Q&A is for questions, and it really helps us to track things. And what we're going to do is leave at least 15 minutes at the end of the hour to have our speakers, Justin and Lori, address your questions. And we also have May, and in addition, Kathy Wibberley from the TRCs to help answer those questions as well. So without further ado, it's my pleasure to introduce our two distinguished speakers. We'll start with Lori. Lori Archibald Pannone is a physician specializing in geriatric medicine and an associate professor of medicine at UVA. She served as the medical director of the UVA Geriatrics Outpatient Clinic and the lead physician for GeriPal. And I'm going to say it just once so people don't have to keep saying it, but that's the Geriatric Engagement and Resource Integration for Post-Acute and Long-Term Care Facilities, GeriPal. She graduated from Johns Hopkins and then went on to get her medical degree at Vanderbilt and went to UVA for residency in internal medicine, infectious disease research fellowship, and geriatric medicine fellowship. So welcome, Lori. And Justin, you have to tell me mutter or muter?
It's mutter like butter.
Mutter like butter. Justin Mutter is the section chief of geriatrics in the Department of Medicine at UVA. His clinical and research interests include the care of homebound older adults, including those living in long-term care environments, and the intersection of clinical services with telehealth for higher risk adult populations. Dr. Mutter is the medical director of UVA's Virginia at Home House Call program, which is fully integrated with telehealth. So I think they're going to go kind of back and forth through the slide deck, and I'll pass it over to you, Lori.
Great, thanks so much. Thank you for having us today. We're excited to share what we've done and what we've worked on over these past couple of months in our GeriPal program. And again, Justin and I are here today to tell you about it, but we're representing a large team that's worked closely from a lot of different disciplines to pull this together. So next slide. So Justin, you want to give a little background?
Yeah, so a little background to our intervention. As Dr. Ramers said, we know that the long-term care population in particular, and also short-term acute rehab, has been a very high-risk population during the COVID era. Earlier in the pandemic, we were looking at, very state by state, but nationally, around 40% of all deaths were those living in the facility environment. More recently, those numbers have decreased a little bit, but are still fairly staggering. 25 to 30% of all COVID deaths currently have occurred in the facility environment. And really, one of the other striking statistics is that nearly 20% of all persons in the United States living in a long-term care environment have been infected with COVID in the last almost year now. So, we know it's an extremely high-risk population, and certainly in the state of Virginia, we were starting to see outbreaks in late March, early April, and came together and said, what can we do to try to mitigate outbreaks in our area facilities in Central Virginia, where the University of Virginia serves a large both urban and rural population. What were the modifiable factors that we could potentially improve upon to reduce spread and also reduce mortality in these environments? So next slide, please. So we know that long-term care environments and facility environments more broadly, congregate settings are extremely high risk for spread of COVID. One of the other challenges is also not just the environment itself, but also the ways in which care is delivered in these communities. We'll say a little bit about that. So next slide, please. So we know that there is tremendous heterogeneity across facility environments in the United States. We have multiple different subtypes of facilities, and we have multiple different ways in which people receive medical care in those environments. Sometimes the primary care provider is on site and is on site frequently. Sometimes the primary care provider for those individuals is not on site, and the individuals actually transfer via facility provided transportation to the primary care provider's clinic. And so there are lots of different models for how clinical care is provided, which makes it very challenging to think about some sort of intervention in these clinical contexts. So it's really critical for us. One of the things that we felt from the beginning of our experience was we needed to understand our facilities. We needed to understand what resources they did and did not have. We needed to understand how they were set up, who the primary providers of medical care were in those environments. So next slide, please. So I'm not going to go through all of this list in fine detail, but this is just to, again, reinforce the incredible differences that exist between and among facilities across the United States, and certainly in our communities in Central Virginia. There are lots of different subtypes of facilities. There's all kinds of different grades of post-acute care, all of which involve different staffing models for who is present to deliver care. There's continuing care retirement communities, which brings together a lot of different subtype populations, including independent living, assisted living, and then long-term skilled nursing and post-acute care and many CCRCs. Assisted living facilities, of course, there's a lot of heterogeneity across even those environments, and also memory care units in most states are embedded within assisted living environments. So lots of different high-risk congregate settings for us to think about and trying to devise an appropriate model for intervening in the COVID era. Next slide, please. So there's also tremendous limitations posed by the COVID experience, by the COVID lockdowns, of course, and we've all, I'm sure, no matter where we work and what kind of work we do, we've experienced this in our own communities. Limitations of residents not being able to leave the facility, so automatically switching to telehealth models for residents. Limitations of visitors, and that can even include various medical teams, particularly for academic hospitals. One of the things that we saw was facilities were very reticent to have LIPs on site in many ways, but also especially extra learners, so residents, medical students, nursing students, et cetera, who would have in the non-COVID era been accompanying us on site. Can they still get transportation to and from various clinical sites, and is that transportation even made available in a situation where people might be transporting persons under investigation with concern for possible risk of exposure to the driver, for example? So lots and lots and lots of challenges posed by COVID lockdowns that sort of are superimposed on the challenges that exist already in delivering coordinated care in these types of settings. So next slide, please. And this is just to reiterate that we needed to think about in our model all of these things together, because all of these things come together at once and provide significant barriers to the delivery of coordinated care in a particular environment, especially in an outbreak setting. It ranges from the need to think about PPE, the need to think about infection control and prevention. And here I'll pass it over to Laurie.
Great, thanks so much, Justin. So thinking back into the spring and really needing to come up with creative solutions to take care of our patients in these facilities when we may not even be able to physically go into the facilities is how we wanted to incorporate or needed to incorporate telemedicine into this model. So we'll talk a little bit about the other steps that went in before we even got to the telemedicine piece. Next slide, please. So we had some overarching guiding principles to our Jerry Powell program. We really wanted to have to develop an optimal response in terms of COVID outreach to post-acute and long-term care facilities. And we really knew that had to come from an interdisciplinary, interprofessional team, that we needed to involve multiple stakeholders to understand the complexity of the communication and transitions and multiple care sites that our patients are in. We wanted to have sustained communication and really develop relationships. We partner with a lot of facilities in our region. And so making sure that we have communication with all of them was really important. And we wanted a systematic approach to integrated patient care, especially in outbreaks. Care can be challenging, but in outbreaks can be even more challenging in terms of staffing. And so we really wanted to come up with a way to systematically approach this to be able to optimize our patient care, recognizing that whatever we developed, like everything with COVID, needed to be adaptable. And we needed to have reflexive innovation to be able to adjust as we went, since we were all in new territory. Next slide. Justin.
So, and we did publish some of our experiences, not all, but this is from a slide from one of our first publications led by Laurie that looked at one of our earliest interventions in a particular facility in our region. And this slide sort of looks at the 5 key components of how we decided to intervene in these communities in an outbreak setting, and Laurie will say more about that in a little bit. Next slide, please. And just briefly, we did have some positive outcomes, and again, we'll say more about this in a little bit, but we did try to sort of track how we were doing relative to national data, relative to other communities and early publications from the CDC in terms of what was happening in other long-term care environments. We did see, thankfully, in particular, a lower mortality rate and in general, lower hospitalization rate than was commonly being seen at that time in several other facilities nationally. Next slide, please.
So what exactly is the Jerry Powell program and how did telemedicine fit in? So to go into a little more details of that, next slide, please. So as we mentioned before, Jerry Powell is a quick way of saying geriatric engagement resource integration for the post-acute and long-term care facilities. And really we wanted that name to kind of globally represent what we were doing. We weren't there to be the ones with all the knowledge, giving it to somebody else. We weren't there to have all the answers, but we were there to engage in discussion with our long-term care and post-acute care facilities to determine needs, resources, and to be able to bring together resources in the community, especially with quickly changing resources and resource options. Next slide. So we had the different components of our Jerry Powell program and 2 different arms of it. The first arm was in COVID prevention. And so this was the first part of our intervention in March and early April, was to develop a Project Echo series with our regional facility partners and invite them to participate in this series to really bring everyone together and develop that collaborative community. These were at first daily sessions where we would meet for an hour each day to review needs in the facilities, issues that were coming up, concerns, and changing guidelines or guidance from national organizations, as well as local response. And so that was the series that really developed those relationships more fully and built this community to allow for us not just to share information, but also to receive information in terms of what needs we could address, what needs were needed to be addressed by other parties in the community that we could perhaps reach out to and engage, as well as to have facility administrations and nursing staff speak to each other, to be able to share their best practices, to be able to share their innovations, to be able to share how things were going, and to be a support community as well, to really be there for each other in such uncertain times. In addition, we had our nurse liaison who is a registered nurse who would contact facilities directly and really develop individual relationships with often directors of nursing or administrators at facilities to get a more detailed understanding of their needs and what we could do to help. And where we'd have Project ECHO to be that larger group, this would be a more direct communication to really go through details of needs. So perhaps things like we're running out of gloves, or we don't have any gowns, or how do we do testing? Things that are facility based or that facilities may not want to bring up in the large group. We had our nursing liaison there to really help to integrate that. And that nursing liaison role was also an integral part of the telemedicine consultation. In addition, we offered infection control advisory. We would consult with facilities and so provide infection control, and in terms of getting the CDC guidance, changing guidance often, as well as to how do you implement that in your particular facility. And so we would provide at first in facility based infection control consultation, but then as we moved into March and into April, that became remote. In addition, we were offering remote social connections with our medical students to connect directly with residents. Still, and certainly early in the lockdown, the concern for social isolation is great. And so having some connections with others in the community was a critical part of this as well. And then of course, our telemedicine consultation service, which included both pulmonary critical care as well as geriatrics and palliative care. Next slide. So an example of one of the first kind of integrated resource initiatives that we were able to take through our Jerry PAL program is in our early days of the Project ECHO series. We were hearing a lot of challenges from local facilities about testing. And there was even concern that patients, residents had to leave the facility to get testing. And so we were able to, pull together stakeholders with our local health department, local academic labs, to be able to come up with a system throughout the health district that could deploy at the time testing needed to be approved, that could employ approval for patients in facilities, that could then bring the kits to the facilities if they didn't have it through the health department, transport them to the academic lab for testing, and then have a quick turnaround time. Because in the beginning, that was quite a challenge, was both to get the patients tested as well as to get that result done quickly. And so we were able to facilitate the rapid turnaround for in-facility testing in coordination with some of our community-based partners. So that was an example of what we were able to do kind of from that listening first from the Project ECHO. Next slide. So our telemedicine consultation through the Jerry PALS program, again, had two arms. It had the COVID-19 consultation with pulmonary and critical care specialists, as well as geriatric and palliative care consultation as needed. And they were set up with a virtual visit, and we'll get through a little bit of details as we move forward. But we would deploy an iPad to the facility with an audiovisual app to allow for a virtual stethoscope, otoscope, and vital signs in real time. It did require faculty staff to assist with the visit, to be there to provide this. And for facilities that were in COVID outbreak, working closely with our health system, we were able to deploy what we referred to as the COVID kit, which was essentially the iPad and the virtual tools for stethoscope, to deploy that often within 24 to 48 hours to be able to have a rapid response to the ongoing needs of the facility in outbreak. And so that's what we would get to the facility to facilitate the telemedicine consultation. Next slide. And so in addition to the COVID kit, we needed to work closely with our health system and our legal team, which we can talk more about the contracting process if anyone has questions, but to rapidly deploy contracts to be able to provide care within these facilities. And so that would be the first part, is to allow our providers to provide care within these facilities if there wasn't already an agreement, to deploy the COVID kit to be on site, and then to start with virtual daily rounds. And our virtual daily rounds were a time via a HIPAA compliant web-based interface to bring together our team of our pulmonary critical care specialists, our geriatric and palliative care specialists, our nurse liaison, and telemedicine specialists, as well as the facility-based often director of nursing, or at least representative of the nursing staff, administration, and importantly, their LIPs, their MDs, their NPs, their PAs, the primary care providers for the patients in the facility, because the goal was to be a consultative service there at the request of the LIP. And so we certainly wanted to make sure that everyone was there together to make these, for this discussion, to make these decisions. So we would, the facility would bring together a list of vital signs on all COVID positive patients or patients that were concerned under investigation for COVID. And our team would have those vital signs to review ahead of the daily rounds. Then we would all get together for this session, and we would quickly go through any patients of concern. So the nursing staff overnight, was there anyone kind of on top of the list that they were concerned about? And we discussed those first. We would then go through and quickly review all of the vital signs to see if there are any concerning vital signs on the list, things that perhaps may not flag in kind of normal vital sign measurements, but in COVID, those vital sign flags are different, and certainly in terms of changing vital signs was important. So that was something that we would track daily. And then we would also provide information on the inpatients. So for patients that were at our hospital, we were able to give updates to the facility, both to assist in kind of the communication with perhaps the family or others involved, but more importantly, in terms of transfer. So for patients that needed to go transfer back to the facility would need to often have lead time to be able to prepare for that, because the outbreaks are almost universally a staffing crisis. So when could they receive that patient back safely would be in coordination with us and the inpatient team to be able to have a couple days to know when this person's getting closer to discharge. Similarly, we work to facilitate transfers to the hospital. So if someone was in the facility and needed transfer to the hospital, there was the potential to work directly with our bed center for a direct admission. And then through these rounds, we would also identify residents who would, either the LIP would request or based on vital signs would request a telemedicine consultation to then do later that afternoon. And again, these virtual rounds would be held every day. They were 30 minutes or less and highly structured to be able to get through the information with a very busy group of individuals at the facility. Next slide. Next, thank you. So in terms of our response, as Justin mentioned earlier, when we reviewed the data in our early interventions, in our early facilities, we were able to see a lower mortality rate for the patients that we were, for the facilities that we were working with compared to the national average at the time, as well as a lower hospitalization rate. And while those metrics are important, another piece to highlight in that is we were also able to ensure goal concordant care. So ensuring that patients in the facility received the care that was in keeping with their goals of care. So if their goals of care were to be hospitalized, then to facilitate that, but if their goals of care were to remain more palliative and remain in facility for treatment, then to be able to facilitate that as well. Our components were well received by the participating facilities, and some of the key innovations to highlight again are the interprofessional team, including physicians, nursing, emergency response, our local public health was critical in really integrating and bringing the community of resources together to help support our facilities. And to be able to adapt in real time. Things continue to change quickly, but certainly in the spring and summer, we're changing very quickly. And so having those community-wide resources together made that possible to do in real time. And a key challenge, and we can talk more about this perhaps in discussion, is that the telemedicine consultations do require on-site facility staff to facilitate that. And so again, in outbreak, staffing can be a challenge. And so, who can be that telemedicine presenter? Often it is a nurse, but it doesn't have to be a nurse. And so we could engage and train anyone on the staff at the facility with kind of working knowledge of the device and the tools to be able to facilitate that and then have the physician on our end walk them through exactly what needed to be done. They did not need to have a high degree of medical knowledge to be able to do that. And so we would often engage with perhaps people who weren't involved in clinical care. So for example, directors of marketing, people who in an outbreak setting perhaps didn't have a clear escalation of their role, but could assist in the implementation of the telemedicine in the patient's room. But that continues to be a challenge that we can discuss further. Next slide. So some of the lessons that we've learned through this program and over the past, gosh, I guess almost 10 months of living in the COVID era. As we know, COVID is complicated. We have learned a lot. We still have much to learn, and being creative, innovative, humble, and really kind of listening to the needs of our community is a critical piece of that. In terms of COVID-19 in our long-term care facilities, one, I think, topic to highlight that is important, outbreaks are not inevitable. Outbreaks in facilities of COVID-19 is not inevitable. And if a case occurs in a facility, devastating outbreaks are not inevitable. Infection control, when implemented appropriately and correctly, has been shown to be able to both prevent outbreaks from occurring and then to prevent them from spreading within a facility. So really focusing on infection control is critical, both in terms of prevention and prevention of spread. And again, telemedicine in this role proved to be highly beneficial, but in our program, didn't stand alone. We needed to first understand the needs. We needed to understand what the facility could support, assist them in the implementation of the telemedicine, and then we're able to use that as a tool to provide patient care as well as to facilitate communication and potential transfer of patients within the care community. And that was really the key, is to work together as a care community to ensure that our patients are getting optimal care at all sites. Next slide. So in short, a few recommendations that we've kind of learned from our experience thus far and continue to learn as we move forward. For providers who have patients who live in facilities, as mentioned before, kind of know who your patients are that live in facilities, know where and what type of facility they're in. That way you can understand or know the facility's process if that patient were to test positive or what their vaccination plan may be. And to really be proactive at contacting the facilities to make a plan for your patients. And then to think about what your options for telemedicine could be within your practice, as well as what options the facility may have as well, and what their capability would be. Again, for health systems and hospitals, again, to be proactive in that communication is critically important to support coordinated care and working closely with state agencies, local health departments, and other organizations to really build that care community, as well as having more global support for the telemedicine services. And then for all of us, just to work as a care community together. We're all caring for the same patients often within our communities, and that coordination of care and communication is really at the core of all of it, especially these most vulnerable populations. Next slide.
So we mentioned a few of the quantitative outcomes. It's always important to have the qualitative outcomes. And one of the things our nurse liaison team member did amazingly well is just loop back with facilities after we had gotten through the outbreak and think about, again, that reflexive learning. We wanted to know what did work well, what didn't work well. And we were very encouraged to get a lot of positive feedback. And not just, as with the first comment on this slide, we should keep this in place without COVID. As soon as we started doing consults, we saw a decrease in hospitalizations that made a huge impact for us to be able to care in place. So the lessons learned, I think, qualitatively as well as quantitatively really extend not just to our COVID era, but also beyond, and thinking about how best to incorporate telehealth within the facility environment. Next slide, please. And lastly, just wanted to acknowledge a lot of people. I won't read this list, but this really took an amazing team of people across our institution and across our community, and really was incredibly important for us to all come together, communicate frequently, and really keep getting better as time went on. So thank you to all these individuals as well. And next slide. And these are just references for our two peer-reviewed publications, if you have interest at looking at those in the future. And next slide, I think we're ready for questions and discussion.
Great, thank you, Justin and Laura, that was outstanding. So we do have some questions that have come through here. I want to ask some of my own first, which is that, there's many people that have been implementing telemedicine and implementing telehealth in some form or another since the pandemic started, but it seems like stepping in the middle of an outbreak situation is an even more complicated time to implement. So can you talk about some of the challenges you had implementing something brand new in the face of a facility that's probably scared and dealing with a lot? Laura, you want to start?
Sure. So outbreaks can happen very quickly and be very complicated and complex. And especially the first few days, there's a lot to figure out. Fortunately, through our relationships that we had already established with a lot of these facilities, we had that ongoing communication already. And so if they were thinking about testing or somebody starting to have symptoms, we were already in communication with them through the Project ECHO program or through our nurse liaison to have a sense of kind of how things are going, so to speak, at different facilities. So often we would be working with the facility already. Once the outbreak occurred, staffing limitations are real. Staffing limitations either for staff that are quarantining, are sick, or otherwise unable to come into the facility can really limit the number of people in the facility, as well as the care needs can of course increase for the patients that are in the facility once they become infected. And so to implement our response in an outbreak would take very comprehensive and high level buy-in from the facility. The administration would have to be on board, nursing staff would have to be on board. It's something that we would really discuss transparently as a group before going into this, so everybody kind of knew what was expected of each party. And not every facility was able to or was willing or interested in collaborating with us in that way. And some facilities, often skilled facilities who perhaps had more nursing on site, had often more options to be able to get those vital signs done in time for daily rounds or to be there with the patient in the room for the telemedicine consultation. Whereas other facilities, perhaps the more independent facilities that had kind of baseline less number of nurses on site may have more staffing limitations in terms of that. But again, being flexible, being open, knowing that every facility that we worked with was different. So we would adapt to what that facility needed. If they wanted kind of the whole package, we're happy to do that. But if they just wanted consultation or infection control or daily rounds, then being adaptable to what their needs are.
Yeah, and you talked about sort of it's almost like the Swiss cheese model of infection control, where we have many different interventions, and hopefully one of them will stop the virus from transmitting. But one really important one that you mentioned was Project Echo, and just if one of you could go over Project Echo and what it is for those who may not know what Project Echo is. Justin, do you want to take that one,
Sure.
or Laurie?
Sure, I can do it. And I think we're joined by Kim Albero, who's our director of Project Echo at the University of Virginia, who may want to chime in. But Project Echo is I think it stands for Extension of Community Healthcare Outcomes. And it's an initiative to develop telementoring programs. So to have community building based on kind of medical care of patients. And so for us, specifically in facilities, to be able to provide that community and collaboration, as well as education, is how we use the Project Echo platform. Kim, do you want to say any more about Project Echo if you're there? Okay.
And just to add to that, and in light of the earlier question about sort of preparation, and I know in the Q&A somebody asked about what types of contracts and agreements. In many ways, Project Echo and the team involved in that work, it became kind of the seedbed for collaboration for this program, because we were inviting administrators and directors of nursing to come to Project Echo and talk with Laurie and talk to Kim, and think about sort of general best practices for infection control. And at that time, we would say, we're developing this, intervention plan, and really sort of doing that outreach and trying to get feedback about what facilities may need, what they may not need. And we developed a contractual system, working with partners, including general counsel and compliance across our institution, and making sure that both from our side and the facility side, that any LIPs, any physicians or nurse practitioners or anybody involved in the delivery of care through telehealth would be supported and would be appropriate from a credentialing standpoint. And so that contract was sort of standardized in the very beginning of this process. And then that enabled us to do this outreach to facilities, so that even prior to an outbreak setting, that was the ideal, so that they could say, hey, we do want to participate in this if we need it. And oftentimes, we'd have the contractual process already completed, and then we were able to respond all the faster in an outbreak scenario. So Project Echo was really important for that communication as well.
So Laura, you mentioned some facilities are strapped and their physicians and staff are really out sick, and they had a lot of difficulties. There's a question coming in from one of our participants about, what are the resources available for facilities that don't have any bandwidth right now, and then also may not have access to specialists that they need, such as endocrinology, rheumatology, or cardiology?
Yeah, I think that really presents an opportunity for telemedicine, and for health systems, for academic centers to reach out to facilities to provide that those specialists or different specialties via telemedicine. That's something that we're trying to work through at our institution, to be able to provide in facility subspecialty care via telemedicine. But it's hard. I mean, that's the reality of it, right? It's hard. Everyone in healthcare or taking care of anyone in long-term care knows that this has been a challenge, and the day-to-day is challenging, much less COVID or anything else that gets thrown our way. So I think that there's definitely opportunities for that. And telemedicine is a great tool within the whole kind of cadre of care.
And then over to you, Justin, a question about, I think you touched on this a little bit, but did the specialists and or geriatricians have to be separately credentialed in a new facility? Having gone through that can take months.
Yeah. Yeah, there are many ways that it could be done. The way that we ensured that was through our contractual process, that INSO engaging in this contract, our physicians or other healthcare providers were we're able to legally practice medicine virtually in that facility environment. So there are many ways to do it, but that's the way that we did it.
And a couple of specific questions about GeriPal and just the implementation and logistics. Did GeriPal provide any on-site care at all?
Yeah, so the goal of GeriPal was to be consultative, so not to take over care of primary care of any patients, but to be there to support the PCPs that are already taking care of the residents there. But we would have the option for facilities that were interested to provide physicians or nurse practitioner on site for either assistance with testing. If facilities needed to do a quick point prevalence survey of hundreds of patients, we were able to deploy some of our faculty on site to be able to assist with the testing, as well as a quick triage. We were able to, again, with kind of legal oversight and a contract in place, we were able to send on site some of our practitioners for a quick triage. And if there was a new outbreak and perhaps the facility-based practitioners couldn't be on site, we could send our team in to do a quick triage evaluation, see if anyone needed immediate hospitalization or kind of get the lay of the land and start that process.
And a question about just a real specific technology question. What peripherals or actual products were used in doing some of these consultations?
We and there are lots of different ones that can be used in any kind of setting, and a lot of it is thinking about what you have available in your community and your institution. How do you adapt that to the needs of the facility? How to adapt that to the needs of the model of telehealth that you're providing? For us, in most contexts, what we used was somebody in the chat box had asked about the particular app that we use for, say, virtual rounding, and that was WebEx, which is HIPAA compliant. Which we used predominantly for our engagements with facilities virtually. We also used for the stethoscope component, we used TytoCare device, which also has a video component embedded within it. So we were able to, for particularly our critical care physician, was able to auscultate and be able to do a physical examination when it was needed and when it was appropriate for a COVID positive individual. So so those were the just sort of two main things that we used.
Okay, another question came in about barriers, especially in those who had not really used telehealth and this was kind of all new to them. Did that pose a barrier to implementation?
So yes and no. So a lot of that had to do with the relationship, especially that our nurse liaison was able to create with these communities. So facilities' experience with telemedicine sometimes had been a positive or negative one in the past. And so really working through, again, very transparently as to what exactly we're providing, how it would work, and being adaptable to the facility. And so the technology that we used was relatively simple. It didn't take a high level of being tech savvy to be able to navigate the technology. And so our nurse liaison and project manager were able to instruct virtually the staff on site and how to use that equipment pretty quickly in terms of maybe a 5-10-minute teaching session to have them understand how to use that technology. And so that kind of decrease that barrier, and then we're able to serve as a resource when questions would come up, be able to just have somebody directly to ask that question to, or just text that question over if they were running into difficulties with the Wi-Fi or connectivity or whatever may come up.
So follow up on that last point you just made, did you see situations where a provider would just have a little follow-up question or just a little tidbit that they wanted to know that wasn't really a full consultation? I would call that the equivalent of like a curbside that happened in your program?
Yeah, I mean, in many ways, that was for the facilities who elected to do virtual rounding with us, that was sort of the curbside. And, we, in that context, our critical care physician or our geriatrician team members depending on what the particular question was, were able to field questions kind of back and forth in that manner. And then there were times when something might be going on with an individual. The PCP did not feel like they needed a formal consult, but wanted to reach out to us, and we tried to make ourselves available for that. And just to dovetail with one of the Q&As, because somebody asked about what happened on the documentation end, we always tried to make sure that we documented then in our EHR anytime we were engaging with a patient. We did not have to document in the facility EHR as part of sort of our agreement. We were really doing all the documentation on our side. Because this was a consult, this was, as Laurie said, we were not taking over the care of the patient. We were there in a consultative manner.
Okay. Really important question here from Carlos Humberto Maldonado. Were the patient's relatives or family members involved in some way during Jerry-PAL?
Often they were, especially so if a patient was having a consultation, in outbreak, visitors were often, or almost always, not allowed into the facility, so they couldn't be there at the time of the visit, but the provider could or would connect with the family, POA, whomever was the appropriate person to be able to relay that information, as well as obviously the facility staff and the primary care provider in those discussions as well. But we would definitely be part of that as well, whether that be treatment decisions, COVID specific, or palliative and comfort measures as well.
So as I understand it, ECHO is often set up as like a hub and spoke type model. So did you have any situations where you had multiple separate facilities that were able to interact with each other, or was it only kind of a one-on-one consultation?
So via ECHO, we had, anywhere from or upwards to 25 or so facilities on an ECHO session together. And so there'd definitely be interaction there, discussion between, different infection control policies or, combat isolation. So in the ECHO session, there was time for facilities to interact. And then often if we had perhaps a facility that we work with very closely in an outbreak or such. And then at the end of that, they would say, if anybody has questions, they can feel free to ask me what this was like. And then they would, carry that communication forward with other facilities, in similar situations. And so it was a lot of both facilitating the discussion amongst facilities through ECHO, as well as kind of beyond ECHO as well.
I think you mentioned at the beginning, you come in with an attitude that you don't have all the answers, and sometimes it's one facility explaining to the other facility really how things have done well, and sharing, I don't know if we can call them best practices because everybody's doing everything for the first time in a lot of ways, but good practices. Yeah. An interesting question here from Mojdeh Amini about how telemedicine can facilitate current vaccine distribution. Have you seen that take hold in any of your facilities?
We have not leveraged telemedicine for vaccine rollout in facilities.
Yeah, Justin, any comment?
I think it may vary from state to state and locality to locality, but I would say our biggest challenge with vaccine rollout, as is the case in a lot of places, is workforce. And so that unfortunately telehealth services have not been able to sort of clearly be helpful in that regard. But yeah.
Okay, can't get through the hour without talking about money. So a couple of questions about funding. The first really about the whole program itself. What was the institutional support that was provided for this program and how was it funded? Justin, over to you.
Sure, and Laurie may have additions. So there were some grant-based funding. We're extremely grateful to partner with the Center for Telehealth and the Mid-Atlantic Telehealth Resource Center and trying to put this all together. And it was done very as quickly as we possibly could while trying to be very careful and thoughtful about how we devise this program. Certainly, a lot of institutional support just in terms of the workforce, I think. But even there, just as the facilities have been strained in their workforce, every healthcare institution in the country has been strained in terms of their workforce. And so it really took a lot of volunteer time, volunteer hours to really get this off the ground and sustain it. So it was a hodgepodge of existing resources, some other resources, really more about not so much getting a lot of other outside funding, but really trying to bring together the best of what we had, think about federal funding as well. We've really tried to think about grant making throughout this process as best we can. I don't know if Laurie has anything to add, or maybe Kathy, but.
Yeah, I would just highlight Kathy Wibberley and our Mid-Atlantic Telehealth Resource Center was instrumental in getting this program feasible or implementable beyond just kind of what we would want to do, but to actually be able to do it. And then in coordination with our Karen S. Ruban Center for Telehealth at the University of Virginia as well.
So maybe I'll see if Kathy or May want to do a little advertisement here for their reaching out to their local TRCs. I am aware of Project ECHO itself that has actually received a grant from AHRQ to conduct long-term care facility echoes really throughout the country. So I put that resource in the chat before. I'll post it again. But Kathy or May, do you want to advise how people could reach out to TRC?
Yeah, absolutely. So if you want to reach out to your local TRC, you can go to telehealthresourcecenter.org. I can put that in the chat box in a minute. And just select what state you're in terms of Find My TRC and be able to select that. The TRCs have, all of them have gotten some one-time CARES Act money, which was part of what Justin and Laurie were talking about in terms of the TRC piece, but we also leveraged FCC money in terms of their CARES Act and connected care. So I think there are many opportunities right now with COVID, and there continue to be many opportunities to really leverage some of those dollars to fund some programs that are innovative and unique.
Great, thanks, Kathy. And then another money question here from Randy McKinney. Did the facilities have to pay for the telehealth equipment themselves or pay for the connectivity? Laura, you want to take that one?
Sure. So through the FCC grant that Kathy just mentioned, nonprofit facilities we were able to provide the technology for them. Yeah, that was through the FCC grant. And otherwise, we were able to loan technology to many facilities as well, not for them to keep, but at least to kind of get through the outbreak would be another option. Justin, Kathy, other thoughts?
Yeah, so those who on the call may be familiar with the Stark Law. There are things that we have to be careful about. And of course, this is a public health intervention and a public health crisis moment. But particularly for-profit facilities, we couldn't just sort of give everything away to say, oh, because we weren't trying to drum up business in any way. We were trying to provide a public health service. And so there was this sort of loan process with a very small payment for that technology that then allowed us to engage in a contractual process that met all legal standards.
Great. And I think I've just time for one more question before we wrap up. And it has to do with vulnerable populations and equity and how we can make expertise available to the places that it's most needed. So how might the Jerry Powell experience it really inform the way we look at telehealth for vulnerable populations? Laura, you want to take that one first?
I think that's a critically important topic that we need to address. I think that what this particular program has shown is that, in facilities that we can implement this technology with support in the facilities. I think that there's a lot of opportunity in, all of our facilities already had Wi-Fi capability and they already had existing infrastructure. So for places that may not have that, or for at-home care, I think there are a lot of other potential for options as well. and Justin's looking into some developing a Virginia at Home program, perhaps he can speak to, but to also be able to reach vulnerable and rural populations. You want to mention that a little bit, Justin?
Yeah, I think access is critical for our vulnerable populations, no matter what communities we're talking about and where they live. And certainly in our experience, thinking about other vulnerable populations, either those in congregate settings that are not long-term care facilities, or those, say, who are homebound in the homebound population who have had extreme difficulties accessing proper health care during the pandemic. Thinking about those populations is critical. And how do we roll out telehealth services to those individuals? How do we make sure that, particularly for our individuals who have barriers, either financial or geographic, to having either appropriate cellular or Wi-Fi capability in their homes or in their communities, can really get that access? So those are rate limiting steps. We have got to absolutely do that for our vulnerable populations to really be able to roll out these innovations and reach as many people as we possibly can.
Great. Well, thank you both for your expertise and for enduring a blistering round of questions. Lori and Justin, really appreciate having you here. I'm going to toss it back over to May to close out our session.
Thank you, Dr. Ramers, and thank you again to our speakers, Dr. Lori Archibald Pannone and Dr. Justin Mutter. Just to let you know, our upcoming sessions will begin in February. We will be looking at FQHC program models in post-COVID and health professionals training models post-COVID. You'll find the registration information on the Telehealth Resource Center website. Next slide, please. And I just want to say thank you. A reminder again, if you are interested in your CE credits, your deadline is February 10th. So please remember to get in your information before then. Once again, thank you to our speakers. Thank you to Dr. Ramers for the great facilitation. And thank you to all of our attendees for staying with us today. Have a wonderful day.